Gottfried, chemotherapy. You're the only medical oncologist. What's your go-to frontline regimen in an otherwise healthy, uncomplicated ovarian cancer patient?
Great question. I think, there is not one standard of care. I think...
no, but you're the expert.
I think due to the recent data on intraperitoneal chemotherapy, on dose-dense weekly Taxol, which have been disappointing in my opinion, that there's no clear benefit regarding PFS or overall survival. It is standard Taxol carbo, 6 cycles.
Weekly or every 3 weeks?
Every 3 weeks. I think there is a study where Bev was given, and there's a subset in those patients that didn't get Bev, where apparently weekly may be better, but I do think it's a well-powered, large study, and if at all, these differences are minimal. I felt that patients getting weekly Taxol had a harder time
They do.
Maintaining the treatment intervals, so I don't think it's a major difference, and I think we should focus on adding new biologics, looking at appropriate subtypes, rather than focusing on optimizing chemotherapy. Yes. And hopefully not another new trial that will look at 1,500 patients.
Right. And it's my sarcasm, get a bigger knife, I get it.
Yeah.
Getting a bigger knife in the OR, it doesn't help, and these minor tweaks of carboplatin paclitaxel don't help. But I'll bet you that my 3 colleagues here, I bet you that they don't do every 3 weeks. Let's see what they, and 3 week is fine, I would never criticize it.
Yes.
So Rob, what's your go-to regimen?
Every 3 week.
Really?
No, just kidding.
Yeah, see, right. Because it's not.
Yeah.
And
so
and neither's mine. Mine's dose-dense weekly too.
Yeah. Well, so let me just say in the patients that have bulky disease, we are doing a lot of dose-dense because we can't get bevacizumab, which would be a reasonable also alternative in the frontline setting, covered in my state. So we do a lot of that. I am sympathetic to the high rate of treatment alterations you have to do in dose-dense in patients who have optimal minimal residual disease.
So for dose-dense for our audience, it's 80 milligrams per square meter of paclitaxel without a break.
Without a break.
And then carboplatin at AUC, generally in the US, of 6 every 3 weeks.
That's correct. So I'm sympathetic to that, and I would say that where the patients live also impacts that.
Matters.
And so I would say that on average, the patients that I see, because we have a little bit of a different patient mix, they're staying for trial or they're going home. And if they're going home or they're coming back, we can't do it weekly, and they do it every 3 weeks. So I would say there's a decent proportion of them.
Matt, weekly or every 3 weeks?
It's about half and half, and in fact, it's getting less dose-dense now as more data accumulates, and just the enthusiasm for selling it as a major step forward, I think, is waning.
Katie?
I'm really interested to know also not just dose-dense, but IP therapy, whether you're still doing
Same
it or
thing.
not.
It's over. It's out.
It's out? Over.
Wait a minute. You have Katie. She's gonna tell you the IP is the way to
now
go.
Katie will tell us the real answer. Yes.
No, I think, it's like you said, we didn't do the right trials. So I think that I agree, we both live in rural states, and so patients can't come every week, and that's just a deciding factor. I do think the data that we have from the Japanese study and also GOG 262 show us that on high-risk patients, dose-dense is better.
Yeah.
And we extrapolate that to neoadjuvant, actually. So
Yeah.
we're kind of making stuff up.
Same.
That's what you were
So
saying.
we want to chemically cytoreduce someone as much as we can so we can get to a successful interval debulking if that matters. Again, we're basing this on, retrospective data, but we do use that. And then in our patients who are really maximally cytoreduced, and especially in our patients with BRCA mutations, we do like to get IP chemo in. And we've actually gone back to the 172 regimen because we think 252 made too many
changes.
Yeah. So, but we're using a lot less. We're using it a lot less.
But remember, we're not going to get into IP here.
Yeah.
I just can't let you get away with that.
Yeah.
So the 172 is no longer valid today because at least I think it didn't have the minor advantage of dose-dense weekly. So it only arms 1 and arms 2 of 252 asked one question: putting the carboplatin in the belly or putting it in the vein, and there's no difference.
With Bev.
With that.
Listen,
And that's important. It's important
you
because
guys got this one. We're going to get into it. So Bev negates the weekly paclitaxel
that's
advantage.
your conclusion.
That's your conclusion. That's the 262 conclusion.
Exactly. That's exactly. And so that's all
Based
of our.
on
That's all of
underpowered
ours.
subset.
That's all of our.
But
I mean, we're
if it negates the weekly, then it actually should pay 252 better. not make it worse.
I'm not arguing with it. I'm just saying that's been our conclusion based on these two steps.
You see what I'm saying, though?
Yeah.
It should, Bev is if it was positive, but it's not positive. Bev would make a positive trial negative, not a negative trial positive.
No. So the incremental benefit of the Bev, when all of those groups did better, and your 262 was a suboptimal population that had half of the PFS of the optimal study. Okay, so the incremental benefit for Bev on the weekly in both of those trials was not demonstrated, but we didn't have the proper control arm to actually see that effect, right? Because 26 months in all three arms.
We did a 15-patient study that's negative, and so you continue to use it?
Oh, of course. No, so okay, 1,500 patient, you mean?
Yeah,
You said 15.
1,500.
Okay, but let me
You're
just
right,
say
not 15,
right.
1,500.
So
Thank you.
there's one last trial out there that we're waiting on, right?
Yeah.
The Japanese trial that's looking at the dose dense and basically.
And if that's negative, can we stick a fork in it?
Of course
it'll
we
be
can.
done?
Yeah. But I do think it's important to recognize that, right? Because all these alterations that we're making, altering the dose and schedule of 172, now you're going back to it, all this stuff is, and I would say even 172 had an appropriate control arm.
But I
Probably an
think-
appropriate control arm, but it was almost weekly. You're giving IP
2 out of 3.
Taxol, and so you have
That's right.
and you have prolonged exposure to that. So
right.
not only is it not, you're not just giving it 2 out of 3.
That's
you're
why it
giving
was
the second
positive,
one
'cause it was a week, right.
So
But I
why do you
think-
think it's not the best regimen?
I hear the discrepancies, but I think it's an important sort of take-home message is that patients go and get second opinions, and they go to one institution and they hear, you're supposed to get dose dense. They come back, you get Q3 weekly.
true.
In another institution, they may be proposing IP therapy. The patient's confused. I think
'cause
we
we're
have to
confused.
emphasize that
why they're
there's
discussing.
room for discussion,
I think we've brought
and we
clarity.
base our decisions on secondary endpoints, like if
there's
you're
no
rural
such-
or you're not. So
And
the
I think
differences
Katie's
are
point
not-
about the BRCA patient, that optimally
true.
studied BRCA
Yeah.
patient, there still may be a role for IP therapy, whether that helps spare their bone marrow for later, whatever the factors are that are associated with it.
Those are the
And
exceptions, yes.
I
So-
think that
And Solo
it's-
1 may change all that if that's positive.
So at this meeting, speaking of IP therapy, we have the opportunity to give heated intraperitoneal chemotherapy at the time of the operation called HIPEC. And at the time of interval debulking, there was a randomized trial from the Netherlands that showed that HIPEC at interval debulking showed an overall survival advantage. So you're going to do that now?
Well, it wasn't a subtle finding. I mean, the hazard ratio was 0.65, 48 versus 34 months. I mean, it's almost too good, as we said. It's just suspicious here. What's going on? Why is it such a good finding?
Why do we do clinical trials if you give IP therapy when it's negative, and then when it's positive, you don't do it?
Well, it's a phase 2.
phase
Is randomized
3.
phase? No, it's phase.
Randomized phase 3 trial. 245 patients were randomized.
245 for
It's a very small sample size. I thought it was
It is what it is.
Okay.
And the patients had to have certain criteria. They had to have very small volume disease at the time of interval site reduction.
Yep.
They had to be less than 2.5 millimeter implants at the end of that site reduction to get randomized to HIPEC versus observation. So, but it's pretty staggering differences in survival. And
So-
again,
but
this
they
is also
also-
100 milligrams per meter square of cisplatin.
Patients got 3 preoperative cycles, HIPEC therapy, then 3 postoperative cycles. So they actually got more chemotherapy.
chemo.
They got 100 milligrams of cisplatin per meter square
That's true.
IP.
That's right.
That's a high dose of
It
cisplatin
is. But-
intraperitoneally. So
But the toxicity was reassuring. I mean,
Toxicity
obviously,
was
the
reassuring.
I mean,
grade
my
3,
take
4
would be
toxicity.
it takes 2 trials to convince anyone of anything.
But
Yeah.
do we,
And the dose dense, we have the Japanese, we don't have the confirmatory trial.
Right.
You talked about 252 IP.
Right.
We're going to wait for the Japanese trial.
Right.
So I think this is what it is.
Yeah.
But if once we have a second trial in this interval side of reduction HIPEC, then I'd be concerned.
But you mentioned a second trial. The Koreans also had a study presented at ASCO.
it was frontline HIPEC.
But they had a subset that had neoadjuvant as well.
Yeah, there was-
And that was the group that actually showed some benefit.
It's kind of
Preliminarily.
like 262.
Preliminarily,
262 doesn't count as the supportive for the dose dense weekly Japanese trial. It's true, the subset suggests it, and in the frontline HIPEC, the interval patients who got HIPEC
Yeah.
also suggest it. So it's close, but we need it.
Some
enough.
hypothesis
Would
generation.
that demonstrate that if you have platinum sensitivity, like in the
Yeah.
Dutch study, that you have stabilization, no progressive disease, that is a subgroup of patients, or it is actually the majority that may benefit from additional?
From that additional thing. And I think that, this is not an unheard of concept that's being practiced already in the clinic. I mean, some people are already doing this. Neoadjuvant surgery, and then they give IP because they had an
IP
optimal that they
chemotherapy.
wouldn't have given before.
Right.
And so, But I think that both of these are cases where the publication is really important, because a lot of the questions we're raising are things that would come out in the peer process.
Thank you
I think
for
that's
that.
when we're going to need to really dig into it.